we're just going to go a little bit through what the vitreous anatomy is, that I'm sure you all know, and then discuss what's the best approach to get the best result when we encounter ourselves in a complex situation. So if you remember, the vitreous is young and thick. As we mature, it becomes a little bit more liquidish, it liquefies, and the collagenous fibers become more obvious, and the attachments, actually the videos, no, the attachments become more loose, and the vitreous ends up detaching. And remember that there are two main attachments that are very critical, remember, which are the one on the disc and the pars plana. So remember to respect always the vitreous base. These are just tips for later on. Respect the vitreous base, do not pull on the vitreous. And another thing, that when you're dealing with the vitreous, use always high cut rate, low vacuum. So the less you mess around with the vitreous, the better the outcome. So if the vitreous stays in the posterior cavity, it's better than if it prolapses into the anterior chamber, and that's worse if it comes out. So as I said, the least amount of vitreous manipulation is the ideal scenario when you encounter a problem. So what happens? You're there doing your cataract surgery, you're all excited, everything's going well, and suddenly, pop, the problem comes. Be prepared, because no matter how experienced you are, no matter how many phaco's and how much surgery you've done, you'll always be encountering. The people that tell you that they have no complications are the people that do not operate enough. So that's the rule. So we all encounter problems. So make sure that you have a clear, schematic mind of what you're going to do and how you're going to handle the complication. First of all, if you're doing a phaco, which is the norm when this happens, stop the ultrasound. Stop everything you're doing, come out of the eye, stabilize things. Manipulation of the vitreous, the less manipulation, the better. I'll be repeating this on and on, because there are few things when we give talks that stay in your mind, yeah? And these are the things, the messages that you need to keep in your mind. That's why I keep on repeating them. Remember to make yourself tight wounds while you're in the eye, and visualizing the vitreous. The vitreous is an invisible collagenous structure that we have, so it's not always that easy to visualize. So it's always good to have some enhancement, something that will help you visualize. And I'll come and touch on this shortly. And remember again, cutting at a high rate is the most essential thing, and using low vacuum and low irrigation is the other two main things that you need to keep in mind. So then once you've stabilized everything, then you can decide on whether you can put an intraocular lens or not. But it's not a disaster if you can't put an intraocular lens in the eye, yeah? So what substances do we have to stain the vitreous? We've got three mainly. Triamcinolone, which costs £4, at least in the UK. Then we've got two other substances, which are triescence and vitrea. These two last ones are the ones that we can use legally in the eye. Because I've highlighted the first, if you can see my first circle in red, it says that triamcinolone is not allowed for intraocular use. So it's up to us whether we think it's legally okay to use or not. There's a lot of evidence to use triamcinolone. I think that if you end up in a court of law, you will be able to defend yourself. But remember that that is something that they highlight in all their packaging, that do not use triamcinolone, the cheap one. The other two are £250 and £50. So it's much more expensive, and you need to think whether it's worth using something so expensive to highlight the vitreous. I personally, if that happens to me, I still use the first one, the triamcinolone, the £4 one. Once you're in there and a complication happens, if you start seeing that the nucleus starts rocking and want to go, let it go. And always remember to use viscoelastic. So once things go wrong, as I said, remove the ultrasound, secure the wounds, and make yourself two nice tight wounds to be able to work in a sealed environment, in a sealed chamber. You don't want to be working through a wound that's leaking all the time. Remember to put an anterior segment maintainer or something to irrigate, to keep the eye with some tone. You don't want high irrigation because that hydrates the vitreous and might cause more vitreous prolapse, but just keep it at a level that will keep the eye formed and for you easy to manipulate with the irrigation and the viscoelastic. And Once you're in there, try your best to do it by manual approach, and when you're in the vitreous cavity, don't chase the vitreous fibers. The vitreous fibers that are prolapsing out of the wound or in the vitreous cavity are the least of your worries. Once you have a problem and the capsule is gone, you need to get into the center of that vitreous, into that core, obviously, and try and cut in that area, because that will end up dragging all the fibers that are in the anterior chamber and everywhere else backwards, or at least lose the connections. So that's a very, very important concept as well. Some people do dry vitrectomies. I'm not a big fan of dry vitrectomies, because dry vitrectomies, maybe they're good for small, tiny, little, vitreous fragments and things, but at the end of the day, you're subjecting yourself to disaster. You're depressurizing the eye, and you have a high chance of ending up with a choroidal if you manipulate too much. So try to keep dry vitrectomy to the minimum. Remember again, low irrigation, low aspiration, and high cut rate. These are concepts that I'm repeating to make sure that I keep in your mind. And then at the end, once you've stabilized things, once the vitreous is out of the way, then you can consider whether you want to put an intraocular lens or not. If you're in doubt that things might go wrong or you don't have enough stability for an intraocular lens, forget about it. Once you've referred to the VR surgeon, they'll be able to deal with this. This is a case of a vitrectomized eye, beautifully handled by one of my surgeon colleagues, and with good enough capsular support anteriorly. There wasn't vitreous, obviously, there, because this eye had vitrectomy before, so it was very safe to put an intraocular lens in. So once you stabilize everything, you put the lens or not, make sure that also you have good antibiotic cover, because these eyes are subjected to a higher chance of infection, so you don't need to make sure that is minimized, the risk of that. Treat the inflammation. Obviously, the more manipulation in the eye, the higher the inflammation, so you need to keep that in mind. So top up your steroids to every 2 hourly. And also make sure that you treat and predict the intraocular pressure rises. And once everything is stable and you're happy with the situation and everything is clear of vitreous and the wounds are all sealed, you can then contact your VR surgeon colleague to deal with the rest if needed. So thank you very much, and I hope I've given you some tips of how to handle these cases. So,
excellent. Thank you very much. Thank you.